and he will talk to us about time for change in residency training in GI surgery. David, thank you very much for coming.
Well, thanks, John and Mike, for inviting me to give this talk. And I thought I'd be a little bit on the edge here a little bit, because I'd like to get a little bit of discussion going. I gave a similar talk to this last week with Chris Ellison in a debate format at the Central Surgical, and it was the questions were more interesting than my talk. Not that my talk's not fascinating, but I'm more interested in sort of feedback from the surgical group. So I have nothing to disclose relevant to this talk, as one might imagine. So why should we change surgery? I'm going to approach this from a completely different angle. Why should we change surgery? It's worked great for hundreds of years. And I would say we have to change it because every single thing that's happened has changed. The residency's changed, as was very eloquently just presented. I think surgeons have changed. We're training different people than we had. And I really very much think the public's changed. Now, I'll try to elaborate on these three topics and try to leave a lot of time at the end for discussion. So residency training. It's an odd picture. This is how I was trained. I was obviously a resident a while ago, and these are footprints in the mud. And what we would do as surgical residents when I was a resident is we would just kind of watch patients. We were there all the time, and we just kind of watch their diseases progress and figure out if they had a complication. We were constantly there looking at them, and I could tell you how long those footprints had been in the mud after watching patients. So it was interesting. You really became very bonded with your patient. There was no shift work. You just basically hung out there, and after a while you got a feeling for who was having a complication and who wasn't, what operation someone should have. And you learned over time that if a patient is in this place, they probably shouldn't have a Whipple. So you eventually sort of by osmosis generated this surgical knowledge. And I just like this picture more than anything. And you did a lot of procedures. You just repeated stuff. You were repetitively doing surgical procedures. You became autonomous over time by just doing the same thing over and over again. And some of it's a little mind-numbing, and parts of residency training 30 years ago I thought were a little bit abusive. I mean, we sat around watching a patient have a complication rather than having dinner with our children. So I'm not trying to defend residency training 30 years ago, but that was how I learned how to do surgery. And this is how I think I visualized surgery in 1990. You learn surgical stuff by osmosis. You just hung around. Eventually you figured stuff out. You did volume. The volume of surgery done in the 90s is significantly higher than the volume of surgery done now, probably mostly for work hours rules. And you did a very broad base of general surgery. You did vascular surgery. I did a lot of cardiac surgery. And you just sort of did a little bit of everything and got pretty good at it. And the point I really want to make at the end, and I think is the really key point of GI surgical training, is eventually you developed independence. And you gradually achieved this over surgical training. And by the end of my chief resident year, I was basically operating independently. And the faculty were around in case there was a problem, but I was basically in an independent surgical practice. I would say in 2012, we're talking about a completely different animal. And I'll talk a little bit about this, and I think John Hunter's going to talk about a little bit of this later. We're now talking about transferability, meaning that you can do one thing and it transfers to another task. I'm going to talk a little bit about very narrow fellowships, which is very different than broad-based general surgical training. And I'm going to try to make the case that this is where the world is going and that we should embrace this. And the residents that we train now really have very little independence during their general surgical 5 years of training. And this is driven not necessarily because they're better or worse than the trainees years ago. I think they're actually smarter and more driven in some ways than we were, but it's just not acceptable. The patients won't accept it, the payers won't accept it, the hospital won't accept it. It's just not happening. One of the great places for training used to be the VA hospital. You know, the residents were just sort of running the hospital, and it's really not like that anymore. It's just not so the paradigm for that type of training has changed. The evidence for transferability, which is sort of how you imagine that you could become a general surgeon that could do everything, I think is completely lacking. There's just no evidence, meaning that if you know how to sew the small bowel to each other, you don't really know how to do a low anterior resection. If you can do a low anterior resection, you don't necessarily know how to do an esophageal resection. Pieces of that are transferable, but the real skills aren't. And if you go back and look at the education literature, it's like expert violin player is not also an expert pianist. The music's the same, they can read the music, but just because you're an expert at one thing doesn't mean you're an expert at the other. And I think this is a really critical point when we start talking about broad-based or narrow-based surgical training. You really have to sort of understand transferability. And if there's really not any evidence for it, the broad basis of general surgery just doesn't quite work. I would say the surgeons of the 90s had a very broad-based skill set. They were autonomous. And they came out of residencies competent to do broad-based general surgery. They weren't competent to do lots of stuff, and they certainly weren't experts, but they could do broad-based general surgery. They were trained to be the captain of the ship. They were in charge, and they were kind of expected to run things, run the OR, accept risk. And I'm going to be a little inflammatory at this next slide. I would say a surgeon today finishing a surgical residency training really wants to be an expert in a narrow area. And we were at SAGES. I was just at the poem session. To become an expert poem surgeon, there's nothing transferable about poem surgery. It's, you know, it's cool, and if you could just do that, it would be ultra cool, but that's pretty narrow. They want free time. There's huge numbers of surveys looking at this. The board has surveyed people coming out of taking their recert exams. They want free time. It's important to them. They want, and we tend to train them as teams, not as individuals, I'm in charge, but as a team. And I think what they don't want to do, and I've hired lots of surgeons in the last 10 years, is they really have no interest in setting up a little office on the corner with a sign out front with their name on it, setting up their billing system, figuring out how to work with an EMR. They're just not willing to do that. And they're really not risk takers. They're not going to go out and try to generate revenue typically. I don't think I was necessarily a risk taker either. So I don't think typically physicians are huge risk takers. And I think you've got to start asking yourself, who's really our audience? When we're training surgeons, is our audience the surgeons, meaning we're trying to do what's right for them? I mean, this is an educational session. Or is our real task to protect the public and to deliver the public something the public wants? And I would make the case that really what we're trying to do is we're trying to generate a product that the public wants. But what does the public want? So the public wants, they don't want competent surgeons finishing 5 years of surgical training. They want an expert. They want someone that's an absolute expert at whatever disease they have. I see lots of people with pancreatic cancer. They come to me and they walk in the door and say, how many of these have you done? How many did you do last week? How many did you do the week before that? And they go, that guy over there does 5 a week. You're saying you only do 2 a week. I think I'm going to go to that guy. And that's a wild example in inner city Chicago, but I don't think that's unusual for any particular surgical procedure. But that's what the public wants. To become an expert, you can't do a broad-based training program. There's just not enough time. You need 10,000 hours of training, very clearly, to become an expert. I also think the public believes that there's no transferability, meaning even if I'm the best pancreatic surgeon in the world, I'm not probably a good heart surgeon. Nobody buys that. I might be, but nobody's buying into that. They probably don't think I'm a really good colorectal surgeon, and I'm probably not, but there's not much transferability in the public size either. And the funny thing about the public is they want you next door to them. They don't want to go have their Whipple in downtown Chicago. They want to have it in North Dakota. They don't want to come to you. They don't want to come from the northern suburbs of Chicago into Chicago to have it. So that's the dichotomy of what the public wants. So how do we kind of deal with that? So if we're just interested in that, we would put a pancreatic surgeon in every little hospital, and then the public would have access to pancreatic surgery. But obviously not completely acceptable. And this is a curve that Dick Bell presented at the Central Surgical about 3 years ago in his presidential address. And I don't put it up to talk about it specifically, but these are case volumes. So this is different surgical cases. So the American Board of Surgery suggested that for sort of broad-based general surgical training, there are 120 index surgical cases that you should do to become a competent general surgeon. And as you can see, if you start looking down here, very few of them are done very much. This is laparoscopic cholecystectomy, and when you get below about 20 cases, and certainly below 10 cases, hard to imagine that you're an expert or even competent if you've only done 5 cases or 1 case of something. So I would say the idea of broad-based general surgical training right now is kind of a lie. It's really not what we're training. People become, they get very good at a few certain things. And it's not reasonable to the public to send a surgeon out and say, this guy can do 120 of these cases. And we're refining that, and I think we'll get down to a smaller core, but it still doesn't make any particular logical sense. And after 10 years, it gets worse. Surgeons' practice narrows, and this is research exam surveys from the board. And it depends a lot on gender, and this is a paper that was presented at the American Surgical last year by Jim Valentine. It matters if you're a man or a woman as to what your surgical practice is and how narrow it is. It matters a lot where you are. If you're in a rural practice, you're going to have a much broader surgical practice, but not quite as broad as you would think. It's much more endoscopy-based, and it matters how old you are. But this is the real problem with subspecialty training in GI surgery, is call. The misery of general surgery is the call. I would say that we made a huge error as surgeons. We picked the abdomen. The abdomen is a miserable organ from a call standpoint. We could have picked the ear, you know, the nose, the chest even, but we didn't do that. We picked the abdomen. The abdomen goes bad, and it goes bad at night, and it goes bad on the weekends. And it keeps people from going into general surgery because you meet these medical students and say, yeah, I love general surgery, but I just couldn't do that call. I mean, I just couldn't do it. And I think it's just it's a poor choice on our part. So who's going to do that? And that's the problem with really narrow surgical practice, the problem with the poem surgeon. So if the poem surgeon could just do poems, it doesn't really work for the public. And who's going to take care of that ruptured aneurysm? You could make the case that someone living in rural Wyoming made that choice and they're going to die. Public doesn't probably believe in that. And who's going to help people make these decisions about what to do with their spouse? It's probably going to be the surgeon. I just thought this was a cool picture. So are the inmates running the asylum? So should we do what the residents want? So the residents want really narrow surgical training, and they want to be autonomous, and they want to not take that much call. And I would say the residents, we have to take into account what they want to do. So 20 years ago, most of people finishing 5 years of general surgical training went off into practice. I would say right now that's not true. 70% of residents finishing training 3 years ago are doing fellowships, and now it's probably close to 100%. And I think then I'll sort of get to my point about GI surgical training. So what do we look at as our core of GI surgery? Because there has to be a core. There has to be some way for us to take call and take care of patients. And how do we get the surgeons down this path that the public wants to expertise? And how do we go about doing that, taking our current training programs and changing them? I would say all surgeons need to know these things. But that's not a very long list. If you think about it, how long would it take to train someone to do those? These are things that are probably pretty important. Endoscopy turns out to be really important in most of the United States. That's who does endoscopy. The next box I put up for this group, should we really be training Nissen fundoplications and laparoscopic hernia repairs in fellowships? I would say the answer to that is absolutely not. We should be training those residents in general surgical programs so that when they leave those programs, they know how to do some piece of endoscopy, and they need to know some piece of MIS surgery. And we need to teach them how to take care of sick people. So my paradigm, and this is my paradigm, so I'm only speaking for myself, is that this is what complex GI surgery is. I think minimally invasive surgery, the word of that is going to sort of go away, and we're going to start talking about complex GI surgery. And this is where how we're going to train people. And we're going to train them into one of these 4 fields: colorectal surgery, bariatric surgery, pancreatic biliary surgery, and upper GI and esophageal surgery. And that's who we're going to turn out. We're not going to turn out that many general surgeons. That's a completely different topic. We certainly need to train people for rural parts of the country, but that's really not what the residents want. So how do we operationalize going from where we are now to go there? So here are options. We can extend our training by a year, make everybody do 6 years of training. I would say that's probably not going to work. It's not specialized enough. We could make these GI fellowships and colorectal fellowships 2 years instead of 1. We surveyed, I'm on a committee on the board, and we surveyed all these fellowship programs, and the fellowship programs said they really didn't have any ability to do that. You know, they don't really have any ability to add another year to it. And the ones that are 2 years long really don't care. They don't care what product we give to them. Transplant surgery says they're fine. We could train hernia surgeons. There's an interesting study that was presented at some meeting I was at from a Canadian program where they train orthopedic hip surgeons. And they can train an orthopedic hip surgeon in 3 years, 2 years maybe. That's all they did. Orthopedic hips, they got really good at it. They were as good as someone that had trained all the way through a residency and a fellowship. But all they could do was the hips. That's all they could do. So we could do, I bet we could train a hernia surgeon in 2 years. We could develop a secondary match, meaning everybody does 4 years of general surgery and we switch it. Kind of a complicated thing to do. There's a lot of monetary problems with that I won't get into, but, and I think probably that's going to happen because I think one day the government's going to say, we'll give you 4 years of funding for general surgery, but not 5. And the fifth one, which is something I want to sort of present to you, is that we could alter the surgical training program and make it a little bit more prone to developing experts. So early specialization is something that's been tried for vascular, cardiac surgery, really working well, peds not so much. I mentioned transplant. Surg-Onc is now its own board. And I would like to make the case that we should do early specialization in GI surgery, certainly for colorectal and for complex GI surgery. And what we should do is alter the last 2 years of our surgical training programs. And I really very much think that if you focus the first part of the training in the first 3 years, you can get a lot of that sort of stuff I talked about earlier, and focus the last 2 years for people wanting to do GI surgery and open abdominal surgery, complex MIS surgery, hepatobiliary surgery, and colorectal surgery with very specific tasks. For colorectal surgery, you ought to be able to do a laparoscopic cholecystectomy coming out of a surgical training program. We certainly need to train endoscopists. And focus our fellowships on not remediating our residents that come out of training, but focus colorectal and pelvic surgery. Focus complex GI surgery on bariatric surgery, not on endoscopy. And this is really the last point I want to make, is that we need to somehow develop independence. And I think that's why most residents, if you ask them, why are you doing that fellowship in MIS surgery? They're really doing it to develop independence. They're not really doing it to necessarily because they think that's what their life is going to be, but they just didn't get that in a residency. And we have to figure out somehow how to build this in. There was a great program at Ohio State where they do great training in minimally invasive surgery, bariatrics. But when you ask the fellows that finished that program, the thing that they learned the most from was taking call in the ER with the backup from the MIS surgeons. That was where they actually learned the most because they were on call and they were there and there was a patient and they had to figure out how to deal with them. And they never got that in their surgical training. So in summary, residents, I think, complete general surgical training, and I'm not alone in this, without adequate preparation for fellowships. And I really think the goal of fellowships should be to enhance resident skills and get them on this path to expertise, not on a path to competence. And that 5 years of surgical training really doesn't prepare a surgeon for independent practice. And we need to take a lot of the complex, minimally invasive surgery and push it back into surgical residencies so that they leave with relatively straightforward skills. They really shouldn't have to go to a fellowship to learn how to do a Nissen fundoplication. And early specialization, as I've outlined, is really the first step towards training an expert GI surgeon. And that really the key thing that we want to develop in our surgeons is autonomy.